Hello and welcome everyone. Today we'll be discussing about the various non-invasive ventilation strategies in the ICU and how do we use and manage them. So what are these non-invasive respiratory supports and their primary goals? The main goal of any of these therapy is to avoid intubation. That patient is in some sort of respiratory distress, but instead of intubating, we are trying to avoid it by these methods and thereby obviously avoiding the invasive mechanical ventilation and along with the associated risks of infection and other tube related complications. Facilitate successful weaning from the ventilation after extubation and enhance oxygenation and ensure safety during the intubation procedure for pre-oxygenation. So these are some of the main reasons where we use non-invasive respiratory support. Now how it has evolved, the older methods like conventional oxygen have limitations as well as the high up to which the FiO2 could be achieved and its role in unloading the inspiratory muscles, especially when there is a respiratory distress, because the work of breathing needs to be reduced also. Just giving oxygen was not enough. So the modern devices like the HFNC, CPAP, NIV, they address each of these limitations. First, the high flow nasal oxygen, it decreases the airway dead space by flushing the upper airway. So the high flow through the cannula, because it is so high, it will flush the upper airway, thereby reducing what we have, that is the anatomical dead space. And it provides a stable concentration of inspired oxygen by exceeding patient's peak inspiratory flow. So if the patient's peak inspiratory flow, especially in a distress situation, is more than the flow that the oxygen mask or the oxygen cannula is giving, then obviously the FiO2 will go down. Because the HFNC provides an extremely high flow which exceeds any kind of peak inspiratory flow, that is why we are able to deliver a stable concentration of inspired oxygen to the patient even if they are in respiratory distress. It generates a very low level of flow dependent positive airway pressure, which may help in developing some sort of a PEEP to keep the alveoli open. It increases the end expiratory lung volume due to the positive airway pressure that develops. Optimizes the patient comfort and enables continuous usage, and may protect the patient from self-inflicted lung injury by reducing the respiratory rate, the minute ventilation, and the inspiratory effort. But mind you, if the patient's rate is not reducing, the minute ventilation is not reducing, the inspiratory effort is not reducing, then probably you are not going in the right direction. These things have to be monitored whenever you are putting a patient on HFNC. Next would be CPAP. It delivers a constant level of airway pressure throughout the respiratory cycle in spontaneously breathing patients. So essentially it is a same pressure, that is the end expiratory pressure, which remains throughout the inspiration also. It promotes the alveolar recruitment, enhances the FRC because there is a pressure continuously present even during the expiration. It improves the lungs compliance and ventilation perfusion matching, leading to better oxygenation. It reduces the pendulum phenomenon, and it provides higher end expiratory pressures compared to the HFNC. It will have its implications, especially when the distress is more, the oxygen requirement is more, and the patient is having airway collapse, and has no direct impact on the transpulmonary driving pressure per se. And next would be the non-invasive ventilation. It delivers two levels of pressure. One is the PEEP, and the next would be inspiratory pressure as well, which is synchronized with the patient's inspiratory efforts. It better decreases both the inspiratory effort as well as increases the tidal volume, and it does affect the transpulmonary pressure more compared to the CPAP. So affecting the transpulmonary pressure can have an impact in the patient-induced, self-induced lung injury of patients who are spontaneously breathing. and it provides a higher end expiratory pressure than the HFNC. When reducing the high inspiratory efforts, the NIV can be beneficial by decreasing the transpulmonary pressure. However, with low inspiratory efforts, it may increase the driving pressure, potentially being harmful. So these things must be kept in mind. Results of the largest inspiratory pressure gradient from a given inspiratory effort compared to the other supports. All these things must be kept in mind when we are monitoring these patients. So coming to what would be our support in case of hypoxemic acute respiratory failure. Now the definition is when the PO2 is less than 60 millimeters of mercury in room air or the PF ratio is less than 200. It is common in ICUs and account for up to 25% of all admissions, with pneumonia being the most common cause. Now having done that, let's go to which would be our treatment of choice or the non-invasive method of choice. Let's see how HFNC fares. It is the first line act, and because it gives minimal impact on the transpulmonary pressure, it reduces the inspiratory rates compared to the conventional oxygen, and the can be initiated in 30 to 40 liters and rapidly increased to maximum tolerated, that is around 50 liters also. Monitoring, you monitor what is known as the ROX index, which is the ratio of the oxygen saturation by the FiO2 to the respiratory rate, and is a clinical tool to monitor and predict HFNC failure. The monitoring is most critical. Attaching these devices is a very secondary thing, but the most and the primary thing over here is monitoring this patient once you've attached, because these things are not self-regulating. The patient still has some regulation and the patient is in distress. We must keep in mind that the patient's distress must be reduced, and just attaching these devices is not going to definitely improve the patient without any monitoring. So these things must be kept in mind. So this is why the risk of delayed intubation and the associated increased mortality should always play in your mind. If you are keeping a non-improving patient prolonged on this therapy, you are potentially killing the patient. CPAP and NIV, currently there is no recommendation for or against them regardless of the underlying condition. The CPAP remains a conflicting thing with inconsistent benefits seen in the intubation rates, no benefits in terms of mortality. The helmet NIV and CPAP are better tolerated in hypoxemia, and they do relieve the dyspnea and they increase the tidal volume compared to the HFNC. The disadvantage with CPAP is the discomfort. Because it's a discomforting thing, it can have impact because the patient is already in distress. So almost 1 out of every 5 patients get discontinued because of this reason. Helmet has an advantage because it is more comfortable, allows prolonged treatment with higher PEEP levels, and may enhance the lung protection also. So if it is hypoxemic respiratory failure, the method of choice would be HFNC, and you can try helmet if it is available because it is a better option. So the next is hypercapnic respiratory failure. In this, it is usually when the respiratory muscles fail to achieve adequate alveolar ventilation, leading to respiratory acidosis. Here the COPD is the most common cause for this happening. Here NIV is the first preference, and it is a reference treatment and the first line without any doubt, especially if the pH is less than 7.35. NIV reduces the need for intubation, the risk of nosocomial infection and mortality. These are clearly proven right now. Physiologically, it reduces the work of breathing, improves alveolar ventilation, increases the FRC, and counterbalances auto-PEEP. The traditional inspiratory pressure of less than 20 and PEEP of less than 4, higher intensity NIV of pressure of around 20 to 30 with tidal volume around 10 to 15 ml per kg has shown to reduce intubation criteria. Prediction of failure by Hacker score should be done and must be done in all patients because it predicts NIV failure and helps in early intubation where the patient is not showing signs of improvement. And it does have mortality benefit. And success indicators are improvement in the respiratory rate and pH. So these must be kept in mind, especially in the first 2 to 4 hours. If you're not finding benefit, then kindly review your decision for intubation. Highly effective in obesity hyperventilation syndrome also, leading to better survival rates compared to COPD. So as far as the NIV usage in COPD concern, it is the gold standard, even better than intubation. But then use your hacker score and also see for improvement. Only then continue with it. And as far as HFN is concerned, it does not support its use alone because it's not very helpful in these situations. The physiological effect is that it provides a continuous humidification, reduces the dead space, delivers positive airway pressure, reduces RR, and prolongs the expiratory time and decreases the inspiratory effort. But these are more theoretical. The optimal setting would be starting with a 3 liter per minute with unstable COPD to reduce the RR and the inspiratory effort. It has a more of a complementary effect where you can use it between the breaks from NIV, but the benefits over NIV are not established, and NIV remains the standard of care over here. Regarding non-invasive support in post-extubation period. Here, the objective is to reduce the risk of reintubation, and this should be given to all patients who are having the risk of reintubation. The prophylactic treatment are applied immediately after extubation to prevent any respiratory failure and the ultimate need for reintubation. Here again, the role of NIV is very, very important, and it is quite established to improve the outcomes. It does improve the weaning outcomes and reduces the risk of reintubations. The high risk factors where we can need reintubation are the age more than 65, underlying cardiac and respiratory disease, mechanical ventilation duration which is more than 7 days, also particularly effective if the patient has obesity. NIV is superior to HFNC in this particular setup. And application, it has to be applied for prolonged period, at least 12 hours within the first 24 hours, and often continuously, especially if your patient is having high risk of the cardiac and respiratory diseases or the patient is obese. Typically, you keep a PEEP of around 5 to 10. You can go up to 10 for obese patients, but it's a support according to the tidal volume you're getting. 6 to 8 is adequate. Respiratory rate should not exceed more than 25. If that is exceeding, you're going into high minute ventilation, then probably the need for reintubation should be considered. Regarding curative treatment for established post-expiratory respiratory failure, NIV is not recommended as it may delay reintubation and increase mortality. So if you're seeing a patient is absolutely in distress, there is really no need to go for NIV trials over here. It is better to reintubate because the mortality risk is significantly high. The exceptions, however, are post-operative patients after abdominal and thoracic surgery because they have the muscle pain during breathing. So in these cases, it can help in reducing the reintubation rate. But apart from this post-op cases, other cases it is very difficult to recommend NIV for patients who are in absolute distress. Here, the role of HFNC is still there. It outperforms the conventional oxygen, obviously. The low risk patients, a patient without the high risk, it can obviously be used. Regarding the evidence in low risk, there is some contradictory evidence also because some trials have shown reduced reintubation rates and others no difference, especially when compared with standard oxygen. Regarding high risk patient and comparison with NIV, it can be used if your reason is primarily hypoxemic. If it is mainly COPD or obesity, then it is not going to help you. Regarding pre-oxygenation before the intubation, here we want to prevent hypoxemia, that is our goal, and prevent other life-threatening complications associated with it. Here again, NIV is the optimal technique and the best first option if you have it available. It does reduce the risk of hypoxemia and intubation. It is superior to mask oxygenation, the face mask oxygen that we use, and reduces the incidence of hypoxemia, that is saturation less than 85 by half, even in low risk patients. Not associated with any gastric aspiration. The setting is a FiO2 of 100, a PEEP of 5, and a pressure support of 10, and it should be given for at least 3 minutes. Contraindication is that there is no such active contraindication other than the patient is actually vomiting during the procedure. HFNC, it does have a role. It is an alternative if the patient is non-hypoxemic, that is the PO2 is more than 200, or there are contraindications to NIV. It allows for apneic oxygenation during the intubation period, so the oxygenation is maintained even when you are attempting the intubation. Appears non-inferior to NIV and face masks for pre-oxygenation, so it has got a role. But it is less effective in cases where the patient is severely hypoxemic, that is PF ratio is less than 200. There it is has not been shown to be as effective as NIV. So in this setting, use a FI2 of 100, a flow of more than 50 liters per minute, and for at least 3 to 5 minutes. So other important considerations are always keep the patient in a semi-seated position around 30 degrees at least, which improves the pre-oxygenation. Sedation using ketamine can facilitate pre-oxygenation in agitated patients. Mask ventilation between the induction laryngoscopy is safe and reduces the peri-procedural hypoxemia without increasing any risk of aspiration. Combining HFNC and NIV may be superior to NIV alone, especially because you are continuing to the process of oxygenation even during the intubation process. But more research is needed during this. Regarding summary of indications, if you are having hypoxemic respiratory failure, go for HFNC. It is the first line. NIV and CPAP can be used, but no consensus. But whenever you are using, use your scores and see whether there is improvement or not. COPD and respiratory acidosis, NIV is first line, HFNC no benefit, at least in moderate to severe cases. Post extubation, again NIV is superior. HFNC may be an alternative in hypoxemic patients only. Low risk cases it can be used. High risk it is debatable. Pre-oxygenation process, again for NIV is the best choice, especially if you are having a PF ratio of less than 200. HFNC is an alternative in non-hypoxemic patients and patients who have any contraindications to NIV. So the future direction is that the precise role of CPAP and helmet in hypoxemic respiratory failure requires further exploration. Optimal pace of HFNC in acute and chronic respiratory failure needs further defining. Further studies are warranted to compare the efficacy of NIV with HFNC in specific post-op contexts. The best non-invasive respiratory support in patients with established post-extubation respiratory failure, it remains unknown. Or we should directly go for intubation. This has to be evaluated further and more. Further research is needed to determine if HFNC or standard oxygen should be preferred during breaks from NIV. So you're giving NIV post extubation, should you give HFNC or oxygen in between that? Those things could have an impact, especially in high risk cases. So to conclude, the non-invasive ventilator support are cornerstone of ICU therapy, and most of the patients who have respiratory distress are getting it. So the main aim is to prevent intubation and its complication. HFNC is the first line in hypoxemic, NIV is the first line in COPD and the post-extubation period, especially in high-risk cases, and HFNC can be tried in low risk. Regarding pre-oxygenation, again, if a patient is hypoxemic, NIV, HFNC, non-hypoxemic. And careful patient selection is important, appropriate setting is important, and most and critically important is the vigilant monitoring of these patients and seeing that they actually are improving when you've added this, and then only we can get optimal patient outcomes. Thank you for your patience.